And we are now live.
All right. This is Senate Appropriations Committee, and we're working on our fiscal 2022 budget, and we are taking testimony today from the Department of Mental Health, and then after that from the Department of Children and Families. Apologize for starting a bit late. We had a committee or a caucus of this whole of the Senate to review our budget adjustments. So we've been working on budget information, but it meant that we've had very little time to catch any break or to get a bite to eat. So sorry for keeping you waiting, but we are going to get started with the Mental Health Department. And so we have the commissioner here and other staff. You've got your business folks. So we will let you take it from here, Sarah. I don't know whether you have documents that you want to put on the screen for sharing.
Yeah, thank you, Senator Kitchell. For the record, Sarah Squirrel, Commissioner of the Department of Mental Health. And yes, I will share my screen and walk us through a brief set of PowerPoint slides.
Okay. The commissioner said that she had a 3-hour in-depth presentation committee, and I took the liberty of suggesting that perhaps that might be a level of detail that we would not entertain today, and that we would ask our the committee member assigned to mental health to get into that more detail. So I just wanted to indicate that there is more information here for anyone who desires it. So thank you, Commissioner.
Yes, no problem. So yeah, we will do a very high level department overview, brief. We'll focus really solely on the FY22 budget, a couple key initiatives that the chair was interested in us addressing. We do have an entire section on results-based accountability. Of course, we want to have data to really illustrate the outcomes that we're achieving across our system of care. That information is included, and we are happy to follow up with any senator who might be interested in diving in a little bit more deeply to that. So with that said, I will just jump in. And again, I also just want to note I'm joined by some of my colleagues from the Department of Mental Health, Deputy Commissioner Morning Fox, our Finance Director Shannon Thompson, and our Director of Quality and Accountability, Allison Crump. So just wanted to know other DMH folks. This is just a quick overview of the Department of Mental Health mission and vision. Of course, we want to promote and improve the mental health of all Vermonters. And we, of course, see mental health as a true cornerstone of health. From our perspective, there is no health without mental health. And certainly at this point in time, as the pandemic stretches on, it is so urgent and important that we continue to focus on having a comprehensive continuum system of care. And we think about that from promotion, prevention, early intervention, treatment, all the way up to recovery. This is just an overview of the department itself. We work with a network of community mental health agencies, designated agencies, specialized service agencies, and designated hospitals to provide services across the state. We, of course, run the Vermont Psychiatric Care Hospital, which is a 25-bed hospital located in Berlin, and the Middlesex Therapeutic Care Residence, which is located in Middlesex. We have just over 300 staff. Most of those are in our facilities, and the remainder at central office, kind of broken down by the typical units that you see with the Agency of Human Services. And I would just note, collaboration and partnership is certainly the key tenet to our work. We're very fortunate to partner with many nonprofit partners across the state, in addition to many advocacy partners. Their work is really critical and really critical to the work of the department as well. This is just a quick visual of our 10 designated community mental health agencies, our designated hospitals, our specialized service agencies. This is a visual just kind of indicating the continuum of care in our children's mental health system. Again, children and families at the center, our promotion and prevention activities, our more community intervention activities, such as our robust array of school-based mental health services across the state, and then more intensive intervention, inclusive of residential services for children and youth, as well as inpatient services.
Before we change on that, or move the slide, for the committee, we actually spent over 3 hours yesterday on testimony, and we heard obviously requests for additional funding, and oftentimes what we hear is from a program perspective, whether we're talking about parent-child centers or we were talking about child care providers, or we're talking about children's integrated services, about how important the services are to families and to children. And my question becomes one of, in the field where you have children who are in your system of care, but they're also, sometimes these children are in childcare settings, and they're also being served by children's integrated services, and everybody is saying they provide the case planning and the coordination and so forth. How do you organize so many different programs in the lives of one child or one family?
Yeah, that is such a good question, Senator Kitchell. And certainly I can harken back to my days working in community mental health, primarily with children and youth. And it really is, it's a lot of integration across departments. I remember specifically, we could use school-based mental health services as an example. I ran a school-based mental health program that covered Lamoille and Caledonia County. I would say at any given time, maybe half, maybe a little bit less than that of the children and youth we served were also in DCF custody. So there is a level of collaboration and communication that has to happen at the community level in terms of who's taking the lead on case management, who's taking the lead in terms of communication with the public schools, who's the primary contact for the family. So that's that, I guess, interagency community level planning that's constantly happening. When it comes to children's integrated services, specifically, there's a portion of that bundle that is early childhood and family mental health. In 2012, those funds were actually taken out of the DMH bundle or budget at that time, put into the CIS bundle, but the provision of those services is still through the designated community mental health agencies. So again, there's kind of that coordination and collaboration between whoever the early childhood and family mental health worker might be with whomever the CIS coordinator might be. And as you mentioned, we could be working with a family that's also connected to an early care and learning setting. So I think it varies regionally across the state. And usually those community teams and those individuals are managing that to the best of their ability and ensuring that we don't overwhelm the families either. Because that's a lot of state government employees potentially involved in your life, or community mental health support workers. So I know there's a lot of thoughtfulness in terms of making sure we don't overwhelm the families that we're trying to support.
Well, it also raises the question, how many different entities are saying they're responsible for case management, and the extent to which a case management's defined. And so often case management's defined by the box of services that your particular program or agency provides, as opposed to what I would hope would be, when you're case management, it's sort of like primary care doctors, knowing that you have to get care from specialized entities, whether a heart condition or or asthma or whatever, but that you have that medical home that's responsible for making sure that all those interventions or the healthcare needs are being organized and coordinated, and medication is not, and it seems to me that in many ways that's somewhat analogous, and that is, how do we organize services, and how many people think they're the case manager for the family, as opposed to being maybe that casework home that has the overall responsibility for the outcomes. Mm-hmm. And that's a larger discussion, I'm sure. But as we hear everybody saying, what I do is critical, this is what I do to benefit families, and so much of the activities are very similar in description. It raises the question, with finite money, how well are we spending money? Are we having to spend a lot of time and resources and coordination simply because of the way that we have got our services and our programs developed? And I have to say, over time, it's been ad hoc, and they get added and they get added, and then it raises the question: how much time does it take to navigate or overcome that balkanization of service delivery? But that's only something that I don't know, it's something that has concerned me for a long time. But and so that's what I was asking as it relates to the children that you have in your system of care.
Great. Thank you, Senator Kitchell. All great points. I know we talk about this a lot at the Agency of Human Services. It can feel like 8 doors to the same room, and it's really our job to ensure that that's integrated, aligned, efficient, but I think we can always improve in that arena. Okay, quickly, I won't go through all of the detail on this, but I did just want to give the committee, a sense of, Vermont is very well positioned to leverage federal dollars to improve our system of care overall. So these are just 3 significant federal grants that we're currently utilizing to strengthen our child, youth, and family system of care. One is really focused on perinatal mental health services for young mothers, working very closely with VDH. This is really critical when we think about just kind of screening, treatment, and access for mothers. So that's something that we're very focused on. We have the Child Grant, which is a 5-year grant that focuses on the integration of primary care and mental health for children. Again, something that we really want to lean into and understand is, it's part of Vision 2030 for the department. How do we truly move towards an integrated and holistic system of care? I think this helps us advance us in the right direction. And then we have the 5-year Samsa Grant with the Agency of Education around AWARE, which again is really working to strengthen that integration and relationship between our education and mental health systems across the state. This is just a very quick visual of the adult system of care, kind of highest level of need noticed at the top. Inpatient hospitalization, our capacity in the system in terms of our level 1 facilities, our general adult inpatient facilities across the state, our secure residential facility that I just noted. We have an array of intensive recovery residences across the state as well. Those are primarily run by our designated community mental health agencies. We also have a peer-run residential program, the Soteria House, that we're very proud of. And then an array of crisis supports and response. So that includes mental health crisis beds that are also run and operated by our designated community mental health agencies across the state, and an expansive array of crisis services. And then as we move down, again, closer to the community, our group residential homes, which are also run and facilitated by our designated community mental health agencies, in addition to the great work that Pathways provides in terms of pairing housing also with mental health services. So again, not a lot of data slides.
Can I ask a question about the Pathways, Sarah?
Yes,
Sure, Senator Sayers, go ahead.
Yeah.
I've been waiting for you to raise your
Well,
hand.
I've been trying to
I was,
listen carefully and not make too many comments.
Oh.
My understanding is Pathways is not available statewide. That it's so for the mental health community and how they're acting. Is there any in? I think they're only in 6 counties. Is that correct?
Yeah, so as a specialized service agency, they are different than the DAs that have kind of regional catchment areas. As a SSA, they can provide services statewide, but they are only providing services in particular areas of the state. So that's correct. They
Yeah,
do
yeah.
not have services and supports in all areas of Vermont at this time.
We've had requests, obviously, to expand. I think Rutland was the next area
Yeah,
that
but-
had been.
I
Yeah,
just worry
but-
about, yeah, I know, and you say that they're a, yeah, I don't know how to put it. I guess I worry about communities that don't have the same advantages as other communities and what's available for services. And we've been hit. I know that Pathways wants to be a statewide program, but the monies are not available. I know I keep hearing they're moving to Bennington, but then I don't hear they're moving to Bennington. So I would like an update of what is the alternative in Bennington County to Pathways? Can you tell me?
And I do know some of the DAs, just to pick up on Senator Sears, and I don't know what Bennington has, but I know that, in past conversations with Mary Moulton, some of the DAs, if they've got the housing vouchers, are combining the housing and the necessary sort of casework support to keep that person in housing. But another part of that is sort of what do we have for vouchers and what do they look like? I guess, Commissioner, to pick up on what Senator Sears is, where do we have Pathways, and then what capacity? Because we have done vouchers, and your screen mentions that shelter and care vouchers, what that looks like, and the extent to which those vouchers are in areas where there isn't Pathways, for example, or how are those resources distributed? Because I think Senator Sears' long concern has been what you get oftentimes depends on where you live, whether it's our court system or other parts of the delivery. But would you be interested in also knowing where the vouchers are, Dick, or as part of that?
No, I'd like to know that we're not completely lacking those services.
Okay.
I do get, we do get complaints about the level of homelessness and other issues.
Yeah.
With particularly with people suffering from mental illness. Many of them, refuse any help. So, I mean, it's not just, even if you had all the best in the world.
So that triggers another thought, and that's the Terra House, which is a peer run. And I believe that that's where I think it's built on sort of a non-pharmacological approach toward mental health. Is the experience, and has the experience been, how is that experience relative to the more conventional treatment with medication? Is there some sense of how the difference in the program? Maybe it has to be who selects to go where, but you've indicated that it was successful, I think. So it raises what are the metrics you use for that?
Yeah, I think when so there's a lot there. And Senator Sears, thank you for your comments just related to equity across the state and access to services. I think we could absolutely follow up with a better sense of where our housing vouchers across the state, DMH has access to a pool of those. And then really what we're talking about is any program that pairs housing, with mental health services to help provide stability in that placement. And as Senator Kitchell noted, that is really Pathways' specialty area in terms of the level of service and support that they offer. In addition to the Department of Mental Health, as you know, Senator Sears, they work closely with corrections as well to provide support for those individuals. And also, many of our DAs also provide that level of support. So I think we could probably dig in a little bit and provide more of an assessment. The Soteria program, and Deputy Commissioner Morning Fox may be able to speak better to the history, it is modeled, it's a peer-run program, and there's a lot of value in terms of it being completely peer-supported and run. It is really geared towards individuals who might be experiencing what we could consider kind of an early episode psychosis, which is maybe early on. Sometimes early onset of schizophrenia can be anywhere from your early 20s into your late 20s, early 30s. And so, one of the fundamental ideas is, can we refer those individuals earlier to a program that might not necessitate the need for medication? And I think Soteria has some very specific criteria in terms of individuals who would be a good fit for that program as well. But when I guess when I caveat the success of the program, it's their ability to maintain stability for the individuals who are in their programs, the reports from individuals and families themselves in terms of the care and treatment that they receive. Soteria won't work for everyone, but for those that it does work for, it's a very effective program. And again, something we're very proud of. Deputy Commissioner Morning Fox, I can't see you, but would you add to that?
Yeah, I think to Senator Kitchell's point, Soteria is not a completely non-pharmacological residence, although they do work with individuals who have either, as Commissioner Squirrel said, it's an early episode or a first kind of break situation, trying to avoid kind of going down the pharmacological road, because long-term use of medications of any type always have other effects on people's bodies. One of the main reasons why people stop taking a lot of the psychotropic medications are because of the side effects of those medications. And so Soteria is really geared towards working with individuals to try and help them manage their symptoms in a non-pharmacological way. That's not to say that they're against them, or that individuals there don't use some medications. They do have psychiatry support and work with psychiatry. I would say that quite frequently they work with individuals who may have been on medications for a short period of time to work themselves off of those medications and remain stable within the environment. Most of the referrals for that facility do come from the community, and so it is different than most of our other intensive residentials, where most of the other intensive residentials, their referral sources are from the hospitals coming out, whereas this model is more prevention model in trying to avoid folks getting into kind of the hospital system of care, if you will. But we can get more data and provide that for the committee if that's of interest, as far as their length of stays, number of people served, things of that sort. I just don't have it on the tip of my hand right now.
Senator Kitchell?
Yes.
May I ask a question?
Yes. I can't see you, but I think it's Senator Ballin.
Yes, it is. Thank you. Just curious, along those lines, Morning Fox, do we have a sense of what the waiting list might be to get in to Soteria House? I know that I've talked with folks associated with the program. It's certainly a unique program, and as the commissioner said, it works for some people, not for others. But I'm just curious if there's been interest in having a similar site in another part of the state.
I'd have to actually go back to the recent reports again. I just don't have that at the top of my head. I know that early on they struggled when they first opened up, struggled with occupancy rates and trying to get people to come there, having referrals come through. I think now that they've been around for a while, the local community has started to embrace that model. I know early on, folks in the emergency room, if someone came in having kind of a mental health crisis, it's maybe an early episode crisis, they were reluctant to refer someone there. And I can understand that. Emergency medicine is, medical model kind of base. But I think my understanding and what I've seen from the data that I remember is that has shifted. And I know that their occupancy, they have been pretty full recently, but I don't want to say specifically if they're at 100% occupancy all the time. I'd really just want to go back and confirm that.
Okay, great, thank you.
Other questions, or shall we move to the next slide? Okay.
Sorry, I moved us.
Yeah, no, I think we should.
Okay, great. So again, we won't be doing the deep dive into the data, but there were some selected data slides that I really wanted to make sure the committee got to see. I know there's a lot of interest in looking at longitudinal data so we can get our arms around trends in the system. So really this is referring to individuals who are served by the designated community mental health agencies by primary program area. So you can see children, youth, and family services and some of the trend lines there. Obviously, we've seen a fairly steady increase in children and youth served in those programs or demand for those services. You see in the red emergency services, which I did want to note this. We do continue to see a consistent uptick across the system of care in individuals who require emergency services. And then we have adult outpatient services, which showed a slight decline in our CRT services. But certainly, again, just wanted to give you a snapshot of what we're seeing longitudinally in terms of the data. Just on the adult outpatient, because everyone always pays attention to where the line goes up or down, of course. This is about a 5% decline. It's a fairly normal fluctuation. Part of this data has been impacted by the pandemic as well. So you can imagine for adult outpatient services, there was probably an impact there. And related to CRT, we have seen, you can see over time, while slight, a steady decline in those served in our CRT program. This is certainly something that we're looking at. I think an opportunity area within the system of care is how do we look at our community rehabilitation treatment programs and ensure that for transition age youth who might be transitioning to adulthood, that they find these services appealing and engaging to them. And I think we might be losing some of our younger people who are opting for other options or not opting for services at all. So that's something we have conversations with the CRT directors across the state, but certainly an opportunity area, I think, for us as we look at different aspects of the system.
What really shoots up, though, if you look at it, and that's the emergency services in 2020. Do you have some sense? I know that there's been some discussion the extent to which the pandemic has created additional emotional distress, suicide, well, certainly opioid use and deaths, but that's a fairly significant one-year increase. Do you see the pandemic as having a major role in that that increase that we're seeing over 12? It's over 1,200.
Yeah, I think it is aligned with some of the trends that we're seeing in terms of demand related to the pandemic. And what I mean by that is that we actually saw a pretty precipitous drop off in terms of access to mental health services when COVID first hit. And there's a lot of, logical reasons why individuals might not have been accessing services in the same way before. But what that also does is you have individuals who might have benefited from services, maybe waiting to access them. And so then, once it becomes more of a crisis moment, then they're reaching out for that care. We are also seeing, I think, across children, youth, and adults, an increase in acuity. We're also seeing a lot of co-occurring. And I know that this is an area that Senator Sears is very interested in, something that we're very interested in, but we're seeing a lot of substance use and mental health issues that are contributing to needing emergency services. So those are a couple of the trends. Allison, I don't know if there is anything you would add to that.
No, Commissioner, I think you really covered it. And I think we'll be talking about some of the suicide prevention efforts later on.
Okay. Any questions about that? We'll keep going to children. No, let's keep going. Children served.
Yeah, and so again, just another data reference slide. We have a lot of longitudinal data included in this slide deck, but this is really getting at, I mean, going way back to the mid 80s in terms of the number of children served in Vermont. And so, you know, we all know this is the result of a lot of complex interlocking factors that, of course, impact child and youth mental health, inclusive of the family unit and system, because they're a part of their family environment. So we know the impacts of, you know, poverty, opioids, other substances that are being used, trauma, adverse child experiences, et cetera. The only other piece I would add, and folks might recall that Vermont was named #1 in terms of access to mental health services. A lot of that is, you know, due to the very progressive expanded access to healthcare in general for children and youth. We're also really good at identifying children and youth who might be presenting with a social, emotional, or mental health challenge. And that's reflected, I think, in some of our special education numbers as well. So again, just a reference slide. So you see the trends that we've been experiencing as a system of care, you know, over the past decade. Again, this is just a quick snapshot of current federal funding that we have received and are accessing. I want to make sure the committee is aware of how we're utilizing and deploying those funds, particularly as part of our COVID response. We did receive a Fema crisis counseling grant. I hope that you're all aware of COVID Support Vermont. Really want to give a shout out to our partners, Vermont Care Partners, who have really taken the lead in implementing this. Which is, you know, really support for Vermonters who might need emotional support, might need access to services or referrals. There's embedded clinicians at the 211 offices. So we're continuing to do that great work in partnership with Vermont Care Partners. We also received a Samsa Grant, a COVID emergency Samsa Grant that we share with ADAP. So we were able to move fairly quickly to expand some of our emergency services and peer services. We just found out that we were awarded an additional $2.8 million. I believe that runs through March of fiscal year 22. So again, another opportunity for us to really invest in areas that will be targeted to mediate the impacts of the pandemic on the mental health needs for Vermonters. And we focused a lot of some of this funding to really, you know, help the designated agencies and other community partners renovate their spaces, you know, purchasing vans so we can have more mobility in the community, and of course, continuing to expand peer supports as well. We're happy to come back and provide more of an update on how we might be utilizing that additional $2.8 million. Planning is currently in the works. We also received a 5-year comprehensive suicide prevention grant from CDC that we will be implementing with our partners at VDH. And we do anticipate, we're still waiting to get official word from the federal government, but some additional funding related to our mental health services block grant, additional funding for suicide prevention and Project Aware. So again, very quickly, our suicide prevention efforts, we utilized, if you'll recall, there were CRF funds that were appropriated for us to utilize. We paired those with some carry forward from the DMH budget. So we could focus on 5 key areas in suicide prevention: expanding zero suicide, expanding our suicide prevention lifeline, targeted resources for high-risk groups across the state, expanding youth mental health first aid, and expanding programs and supports for older Vermonters. Again, we've also received a $3.8 million comprehensive suicide prevention grant, and that's really going to allow us to make a long-term comprehensive investment in our suicide prevention efforts. It will create a more coordinated statewide prevention effort using data to identify vulnerable populations. Again, we have a lot of data related to suicide that, you know, we're happy to follow up with the committee on and share. And also to expand recovery and peer supports, including groups such as first responders. But I will pause there. Allison, Is there anything you want to add to the Comprehensive Suicide Prevention Grant, or any data points you think the committee should just have a reference to?
Thanks, Sarah. I think the only thing I would add is we've watched these numbers go up for over 10 years. And so I think what the department is really invested in is we've had an issue in Vermont with increased suicide rates, about 30% higher than the national average, and going up year after year. We did see a dip in 2019. It is a small dip, and it's still an overall trend in the wrong direction. And so our hope and our concern was that the pandemic would heighten a lot of these risk factors. And our hope was with the appropriate and timely investment, we could stem some of that. And thus far, we've seen that 2020 did not have a spike in suicide deaths as some had been concerned about. And we do want to continue that trend through some of these really targeted efforts. So we're trying to use data to apply intervention where we know it's needed the most. And so that's what you'll see in that list of 5 areas. And then the CDC grant is really more about working with the Department of Health on how do we turn this into a population health issue as opposed to simply a mental health treatment issue. So those are kind of the distinctions between the 2 efforts.
Thank you, Allison. Again, there are slides related to data related to suicides in Vermont further on in the presentation. Again, we're happy to follow up with anyone who might be interested in that.
Last I knew that northern states, there's a ban. We tend to have higher suicide rates than, and I don't know if it's because of geography, shorter, whatever, but there seems to be some geographic link but at least this was the case of a few years ago. The northern tier states seem to have a higher rate. I don't know. So could you describe, I'm sitting here, public health. I suppose when you're talking about data, you're really talking about an epidemiological approach toward the problem. Oftentimes what we see in public health is a desire to legislate, and we've done a lot of public health gains by legislating, particularly around smoking and where smoking can occur and ages and so forth. So from your perspective, how would you describe a public health approach to suicide prevention versus mental health?
That's a great question.
I'm like, maybe I'm the only committee member that is like, what it would be, how would you, what would you define as the critical differences? Are you talking about, population, public health is a population-based, mental health oftentimes is individual patient focus. So, which maybe no one else is interested in that. So we can move on. I can't see my committee. All I can see is screens.
I could provide hopefully a fairly succinct answer to that. I think it's a broad and fantastic question. And I would one thing I could offer from being involved on both sides is it's the difference of where we're putting the resource. And so previously the Department of Mental Health has invested a lot of resources to make sure that if you come in as an individual who wants mental health counseling, that we can identify if you have suicidality and we can treat it. The difference with this grant is saying this is not just for a mental health professional to have that skill. And in fact, we're seeing most folks who die by suicide in Vermont are not served by our community mental health agency. So it's how do we get that awareness out to everybody, out to faith leaders, out to sportsmen's clubs to identify with their friends, out to schools to identify in students, and know how to triage and peer-to-peer assistance. So beyond just a mental health treatment focus and really into messaging, we've got a real issue with rural men who aren't seeking help when they have suicidal thoughts. So just on a messaging front and an education front, approaching it from that lens and spreading the wealth of knowledge there.
That's sort of what I thought you would say, but I thought I would ask. All right, let's go to your budget. because so much of this all comes down to the money and the resources you have to do the work. So we're into the meat of our testimony today, summary and highlights. You're muted, Commissioner.
Not helpful.
No, I know. That's who would have thought a year? How many times do we say you're muted? You're muted. It's just permeated our everyday speech.
Commissioner, if it's any consolation, today Senator McCormick just started jabbing at his screen, and he doesn't have a touch screen. So like, you're doing better than that. So
Thank you. I appreciate it. Okay, so I'll walk us through our FY22 budget recommend. The first two slides are really just, visuals of the overall budget, kind of where the buckets of funding are. Our FY22 budget recommend is just over $280 million. And this just gives you a sense of kind of the source of funds that flow through the Department of Mental Health budget. Obviously, the bulk of our budget is Medicaid. So you can see that Medicaid global commitment funds and then Medicaid investment dollars. And the investment dollars, Shannon, please jump in if I get this wrong. The investment dollars, we can use them a little bit more flexibly, and we tend to use them to support services and supports for individuals who might be uninsured or underinsured across kind of all of our programs, whether that's respite, whether that's crisis services, et cetera. But just so folks understand, some of the nuances between our investment dollars and our regular global commitment dollars. Our budget does represent about 4% of general fund, as you'll see reflected here. Our special funds budget, which is essentially our Medicare revenue, interdepartmental transfer, which is teeny tiny, and just when we're shifting monies between typically AHS departments, and then our federal funds. And the summary and highlights is essentially what we'll be going over in more detail in the next few slides. This pie chart just gives you a sense of where is the money going? What is kind of the spread of dollars that are providing and supporting the provision of services across the state? So about 71% of our overall budget goes to support our community mental health and specialized service agencies. You can see here, and looking at children's services, Success Beyond 6, and children's PNMI, which is our residential programs. It's about 50% of our overall budget. So children's services, our community school-based, our community services that are in our bundled case rate. And then I would just note Success Beyond 6 is our school-based mental health services that is outside of the case rate, a substantial part of just the overall monies. The other thing that I would note, just related to Success Beyond 6, it's a unique fiscal mechanism that was put into place, I think, in the mid to early 90s to allow us to leverage local education dollars. So essentially the general fund portion comes from local education agencies. We're able to draw down the Department of Mental Health Medicaid to then provide those school-based mental health services to public schools across the state. Over 70% of our public schools across the state contract with our designated agencies and specialized service agencies for those school-based services and supports. I won't go too far into it, but that's inclusive of, school-based clinicians that might be working with, kind of a cadre or array of students, and then more intensive one-to-one services for those children and youth that really need a wraparound of services to be successful in their public education setting. It's also inclusive of funding for our independent schools as well.
This is kind of a technical question, maybe Stephanie. The certified match, is that in the 72 million? Or Shannon, do you know the answer to that question?
The certified match is not part of the 72 million. It's other match that the designated agencies are able to bring in. I mean, some of it could be school-based match, but it's other funds that the DAs are able to bring in And we don't actually have that in our budget.
Right.
Yeah.
So, all right, well, I was just wondering whether 72 was included the certified match or not.
Right, it does not.
Okay. One of the things a couple of years ago was a very steep increase in spending in that area. And what we have for sort of the wiggle room under the waiver and hitting our cap. And we were trying to take a hard look at that. Could you just reflect on that concern in terms of, are you seeing some stabilization, or are you still seeing a very aggressive use of that way of funding school-based services?
Yeah, it's a great question. And so we increased our Medicaid authority, I don't know if that's the right terminology, Shannon, so that we could expand school-based mental health services if needed, knowing the demand and the need. I think we have seen that stabilize a little bit. Certainly with the pandemic, COVID is not the best time to be evaluating trends and demand. And certainly it was very, very challenging, I think, for all of us as we had to deploy to these remote and hybrid models almost overnight. How do we maintain that provision of school-based mental health services? So again, just commending the work of our education partners and designated agencies. But I think in general, we've seen a little bit of a leveling off. I would predict that as we move towards recovery and broader school reopening, that we are probably going to see increased need in terms of school-based mental health services. Okay. Again, the rest of the pie chart, you can see where we have our community rehabilitation, treatment, and support funding, about 24% of our budget, adult outpatient, our Department of Mental Health admin, funding for our level 1 beds across the state, the VPCH, Vermont Psychiatric Care Hospital budget, as well as the Middlesex Therapeutic Community Residence, in addition to emergency grants and peer supports. So now I'm going to move into our actual. Oh.
Sarah, I'm sorry. Could I go back to that slide just for a minute, because I want to make sure I answered Senator Kitchell's question correctly about the certified match. Senator Kitchell, were you talking about the general fund portion of the global commitment that the schools give us for the school-based services, or were you talking about the other batch of certified match funds?
I was talking about the former.
Okay, so my misunderstanding and my apologies. The $72,250,000 does include, it's the whole global commitment gross dollar. So of that, the schools provide the general fund portion, which is about 44% in our FY22 budget. So my apologies for the confusion.
Thank you, Shannon. Okay, so now we're going to move into the ups and downs. You do have the spreadsheet that lists these in an Excel format, if that's easier for folks to follow. I'll walk us through the talking points. We always illustrate the gross and then the general fund equivalent, just so folks can see that. And we do have more detailed talking points that we are happy to share with the committee should you want those. But I'm just going to start rolling through, and I will pause for questions as the chair would like to see. So the first item is related to our salary and fringe increases. This is the annualization of our FY21 salaries, life, retirement, health, dental benefits, etc. It's a general fund up of $224,000 and a gross up of $100,000. Shannon, do you want to provide a little bit more of the background on this?
I'm just wondering, could you give me, I'm sorry to interrupt, but how many more slides? We're just getting into salary and fringe. So I know that we have like 4 minutes for children and DCF comes in. So I don't mind having them wait a little bit because we had you
Sure.
wait a little bit, but I don't have a sense of how many more slides you might have.
I think there's probably about 5.
Okay, all
I
right.
can, maybe what I can do is move through them and then pause for questions at the end,
Okay.
which might be most efficient.
Sure, we're pretty familiar with that because we had the 12-hour shift in the budget adjustment. So this is just annualizing it.
Yep, so we can move right through that. This is the annualization of the 12-hour shifts, as Senator Kitchell noted. And then a few more housekeeping items related to the replacement of one-time CRF funds that we utilized before. It's essentially CRF backfill. There's 2 of those CRF reductions noted here. One is related to the costs that were associated with our medical director, and the other was related to travel nurse premium pay. We have our internal service funds here, which is reflecting the increased cost of workers' compensation. We have the reduction of CARES revenue at the Vermont Psychiatric Care Hospital. So we were in receipt of CARES Act funding from the federal government to cover lost revenue at VPCH. So this is the general fund equivalent that we need to fully fund and operate the hospital as we move into FY22. The next up in our budget is related to our EHR system at the Vermont Psychiatric Care Hospital. We have to update our current EHR to ensure that we have a separate training and testing environment for our EHR, as well as some upgrades to our billing system. Because we don't have a separate training and test environment, we have staff learning and training using live data, which of course is not best practice from an EHR standpoint, could potentially lead to errors. Obviously, we want to stay in good standing with Joint Commission, and having a functioning EHR is really critical. So these investments will allow us to upgrade our EHR to make sure that we can accommodate that. The next area, as part of our FY21 budget build, we did have some targets in terms of reductions of expenses. This is just annualizing some of those at VPCH and MTCR. We also have another small elimination of CRF authority due to operating costs that we utilize those funds for purchasing laptops. And then another internal service fund change. This is related to our liability insurance, fee for space, workers' comp, etc. All of these should be fairly familiar to the committee. The next item is an increase to the rate for our residential providers. DEVA has a rate setting process. They basically do a 2-year look back, and we are basically applying the recommendation of that DEVA rate setting process for the PNMI programs that we fund and pay for. Room and board phase down, again, we have been required by CMS to phase down our payments toward room and board. This has been, I think, a 3-phased process. This is the final phase to fully phase down that funding, and the general fund equivalent is listed here. The next item, as we move forward into our FY22 budget, the new level 1 beds at the Brattleboro Retreat have been completed. This is really just the annualization of the operational costs for those beds. The next item here is related to the Wyndham Center. We are hopeful that by July 1, we will no longer need inpatient capacity for COVID positive individuals. So this removes the funding for those capacity payments that we've been providing. I would just note that that has all been funded by FEMA dollars. And the final.
Could you just tell us, does that mean that the beds at the Wyndham Center, I thought they were going to continue as part of the system. Is this just changing funding, or are you basically saying now that we're anticipating with COVID phasing down, these beds will go offline? Could you just clarify?
Yes, so we will retain the capacity of those beds in the system. They will be no longer funded through these FEMA dollars temporarily. They'll revert back to a general adult unit with the typical Medicaid billing.
Okay.
But we will retain that 10 bed capacity in the system of care.
And so this money is being removed. So where does the ongoing cost for these beds come up?
Yeah, so the cost for the Wyndham Center, it's a mix of DIVA and DMH. So Department of Mental Health pays for inpatient stays for those who are CRT, I believe. Is that correct, Shannon? And then the rest of inpatient stays are funded by DIVA.
Okay, but those are reflected or built into your budget for 22. That's what I'm saying.
That's
Even
correct. That's correct. Okay, the final few items here, we have increased federal authority, spending authority due to some increased funding that we've had for our mental health block grant and suicide prevention. An initiative here, this was part of our original FY21 budget build, is implementing mobile response across the state. You know, this really correlates to some of the data and slides that we were looking at. I'll try to keep this short and sweet and happy to follow up with other committee members who might have questions. But we have a real opportunity right now to improve and strengthen our proactive responses to children, youth, and families in the community. This is exactly what this is intended to accomplish. It will allow us to provide face-to-face, more proactive response to children, youth, and families in their homes before something becomes such a crisis that you need to go to the emergency department or access higher levels of care. We are proposing this to be implemented as a demonstration site in the Rutland region. Again, that was a data-driven approach. The ED utilization that we were looking at statewide indicates that Rutland has the highest rate of ED utilization across the state. There are a lot of factors that contribute to that. We think, in addition to Rutland having experienced a really significant opioid issue that we are now seeing, kind of lagging impact on child development. So again, other states who have implemented this have really seen astounding results, reducing inpatient higher levels of care, reducing visits to emergency departments. Senator Sears hosted a great roundtable last Friday. I think it was last Friday. This could also be an opportunity to strengthen supports for children and youth who are in foster care as well, because other states, I think it was New Jersey, for those families who received mobile response more proactively, they were able to maintain those placements 100% of the time. So again, this is just a real opportunity for us as a state system. It's something that, you know, we're very excited about, is aligned with, I think, some of the data and trends that we're seeing, as well as our Vision 2030, where this is clearly articulated as a strategy that we as a state want to do more in. The next item is a recommendation from Justice Reinvestment. So I'll probably slow down on this one a little bit. I really want to make sure that folks understand, you know, what's being proposed and what will accomplish through these funds. Justice Reinvestment, you know, is an iterative process, you know, doing work in the state to try and strengthen coordination.
Senator Squirrel, we have, Commissioner Squirrel, we have 3 members of Senate Judiciary who have lived and bled for Justice Reinvestment. So we're fortunate to have 3 members of our Judiciary Committee who are remind us fairly often about the importance of justice reinvestment. So I do want to just recognize the work of our colleagues, and 3 of whom serve on this committee.
Thank you. And what I would add here, just so folks understand what exactly are we accomplishing specifically with these dollars, this is funding that would go to the Department of Mental Health and ADAP. And really the intent is to strengthen care coordination, referral to services for those individuals who are transitioning out of corrections, on probation and parole, back to the community. And how do we strengthen case management? How do we strengthen connection to services, whether that's mental health services or substance use services? We've been, you know, working closely with the Department of Corrections on this, as well as ADAP. We have kind of 5 implementation activities that we'll be focused on. And again, looking at 3 demonstration sites across the state, because I think we all agree, you know, we can do better. There's incredible opportunities to reduce the high rates of rearrest that we see for this particular population. So this is an area we're excited about. We would be, partnering closely with our community mental health agencies to enhance that care coordination and ensure that these individuals have access to the mental health and substance use services that they need to be successful in the community. And last but not least, and more of a housekeeping piece, this is transferring funds from the Department of Children and Families to DMH. For about 8 years now, the Addison Parent Child Center has had an IFS grant that has included funding from DCF. And basically the review and analysis of those invoices comes through DMH. So our team is actually reviewing that. What has happened, unfortunately, is we have created some barriers for this community provider in terms of the back and forth between DCF and DMH. It's not efficient for us, it's not efficient for the provider. So basically to resolve that issue, we've agreed to transfer these funds to the Department of Mental Health to create a more efficient process for this provider who's doing great work in the community. And I think that is the end. These were some of the key initiatives and updates that I had hoped to touch upon. I don't think time will permit, but certainly happy to follow up on any of these items as the committee would like.
Okay. Thank you. Unless there are other questions, I'm assuming we probably have Commissioner Brown in the waiting room at this point.
Well, I'd like to at least have the commissioner update us on, at some point, on law enforcement and mental health collaboration.
Yeah,
That was
I
such a
agree.
big issue last year. I hope that she could come back and focus on that.
Mhm.
But also like more information about the Brattleboro retreat and what's available.
Okay. I think those are both areas, and I guess the other is the vision for 2030. So there's more information that the committee would like. So we'll schedule time for you to really focus on those areas where we have initiatives underway and understand where what work that's been done today. Anything else from other committee members? Okay. All right. Thank you. We'll obviously have more conversation. And then we'll move on to DCF, which is kind of a nice segue here, since we just left with a transfer of money from DCF over to you. So
Thank you all for your time this afternoon. We
I'm just looking at the committee. Are we all set then? Anything else for the Department of Mental Health? Okay. All right. Well, if we think of anything to add to that list, we'll be in touch.
Sounds good. Thank you all.
Thank
All
you.
right. Okay, so moving on to DCF, and I see we have Commissioner Brown here and Sarah Truckle, and gee, it's quite interesting. You don't have Sarah Clark monitoring your testimony today.
Oh,
So,
she could be watching from YouTube.
May I ask, do you have other than Sarah, or just it's because I only have limited number of screens or little boxes on my screen, so I'm not sure.
It looks like Tracy O'Connell from the Secretary's office is trying to join. She's in the waiting room, it looks like.
Okay.
Yep.
So we're going to get started on the DCF section of the budget. Senator Westman, of course, has that but he's pretty familiar.
According to the thing, I have the family services section.
Yeah,
You have the
so-
child welfare, including the juvenile,
Right,
the
yeah,
facility. Yeah.
Right.
Mhm.
it's shared.
Oh, okay, so Commissioner Brown, do you have a document you want to share with us on your budget presentation?
Yes,
As you
if
know-
they could allow Sarah Truckle to have the screen sharing, she'll pull up our PowerPoint that will walk through the committee.
Okay. And as you know, we probably won't get into the same level of detail that you may have been expected to present on the House side, but we like these summary and highlights. They're very helpful.
Yeah, so you just see we're approximately 970 staff right now, 424 million. When you add in the EBT benefits that don't flow from us, but that we issue out that go through the U.S. Treasury or EBT bank, that gets up to about 500 million or a little over 500 million total for DCF. And then we'll just move over to just to touch on some of the major initiatives you'll see in our budget real quick. An FSD transportation restructure, you know, what you saw on the BAA, raise the age, some transitional housing services, the impact of the Families First Prevention Services Act. We're anticipating some revenue loss, just given the impact on our residential system of care and the new requirements to become a qualified residential treatment program. CDD, you'll see the 3-year the third year of the 5-year plan regarding the rate restructure, what we're calling the flip. We'll get into that a little bit. Again, working with FSD on trying to streamline transportation. And then also, it's not in our budget, but within that debt, 53 million the governor highlighted in one time for the IT fund, it would be the remainder of our Bright Futures information system.
And how much is that, Sean? The remainder?
Sarah Truckle, you want to jump in with that number?
It's 4.5 million, Senator Kitchell.
All right, thank you.
Yep. And then GA, just our initiative to move forward still with the community-based initiative once we're through our public health response in the pandemic.
Hey, Sean,
yes.
could I just, so it's 4.5 in this budget, but the total cost of the system was how much?
We're working on the first module now, and so when we have those funds, that would be for the remainder of the build out. Sarah Truckle, can you remind me what we have available right now for the first module? Was it like just under $1 million?
So we have 2.2 million for the first module, and that's a combination of state funds and CCDF discretionary block grant funds.
Yep.
And then we also, if you recall in our 2019 report, we submitted the total cost of the BFIS system, which was at 6.7 million. So the 2.2 we have plus the 4.5 brings us to the 6.7.
That's what I wanted to make sure people on the committee understood.
Yeah, we knew we'd done a first installment, so the 4.5 is what it will take to complete the system.
Right.
Correct. Yep. And then in Reach Up, you'll see, we project the caseloads to still be much smaller than we had originally indicated in the restatement budget in September. OEO, where you will see the movement of the dollars going to the community-based system from the Economic Services Division. Also, the governor proposed a one-time increase of funding for to increase our ability to weatherize low-income homes. One-time investment of $4.5 million. We are anticipating spending that over 2 years, period of 2 years. And then also, it's no longer the Woodside Debt ID. We're now referring to it as a secure residential Debt ID, and you'd see just the movement of, instead of running Woodside, you'd see us moving money to a contract line item because we'll be contracting hopefully with an outside provider to provide that service in the new program we're trying to develop and are proposing in Newberry. And then moving on, just real quick, just touch on some of the COVID work that's continuing in the department. We're going to be issuing out a new round of pandemic EBT benefits for the school year. We're one of the few states that has an updated approved plan from the federal government. I think we're one of 7 states, and so we're getting ready to issue that out. The stimulus bill that passed the federal at the federal level at the end of December has a 15% bump in the amount of the benefit. It was originally projected to go through June. The new administration has extended that through September. So that's good news for Vermont. And now that we continue in the state of emergency in response to the pandemic, we're able to continue to issue out the emergency full allotment. That averages between $2.5 to $3 million additional dollars going out a month to Vermonters. Also, we continue housing a large number of homeless households in the state. We're approaching 1,900 or just over 1,900 households. Normally, we might be at 200 during the winter at its peak. And providing a lot of support services around that for that large number of households, including mass feeding, where we've are providing meals every day for all of the households in the hotels, just given that there's very limited ability to store and prepare foods in hotel rooms. And so that's just kind of highlighting the work we're doing. Also, FSD continues to work with foster parents in our residential system of care. We have had some positives in youth and out-of-state treatment programs. We've had some positive cases of staff in Vermont and FSD triages with the health department response team and the provider to just react as quickly as possible to isolate and limit the spread. And so far, we've been very successful in that work. Also, we've provided a lot in CDD. We've provided a lot of relief since the start of the pandemic in March, like 4 or 5 different relief programs, almost over $40 million. The good news is the federal stimulus that passed in December includes an additional $12.2 million, I believe. We just received our award notice to help shore up the child care system. And so we're working to identify how we can utilize those funds to support the child care system in response to the pandemic. And also, we've seen the impact of the pandemic on our child care capacity. While we've only seen a 1% reduction in slots statewide, some areas of the state have had a disproportionate impact. The Northeast Kingdom, the Newport area, has seen a 15% reduction in capacity. Rutland, Middlebury, and Montpelier have all seen between a 3 to 5% decrease in capacity. So those 4 areas have seen a pretty big reduction. And so we're going to try to see what we can do to help stem the losses and also bring some new capacity back online. So when we come out of the pandemic and hopefully we see utilization rebound. Right now we're at about 75% of the utilization, what we saw pre-COVID. And so you'll see that in our budget where we have some significant underspend in the CCFAT block grant. And then in OEO, we're trying to continue our work of planning for the phase down and once the pandemic is over, continuing to provide rapid rehousing services, once someone identifies permanent housing, to make sure they have the resources to access that permanent housing and move into it as quickly as possible. And then also just the immense amount of work going on in hotels with our housing providers and other service providers across the state to make sure families and individuals in hotels are having access to mental health services, substance abuse services, case management. Just the stress of the pandemic you can see living in a motel room for 10 months is not a great existence. And so we are trying to provide as much services as we can while it's keeping families safe and warm during the pandemic. I mean, it's a very limiting environment for sure.
Okay. I have a question, and it's kind of tied into so many things that you're talking about, and one is families and stress. Even prior to the pandemic, a significant percentage of children in our childcare systems were children who are not there because of the employment of the parents. They were there for child protective reasons primarily. And childcare providers have talked about, the demands that and challenges that having a larger percentage of children who have either behavioral or mental health or other related issues present to the system. What is happening to those children at risk as you're seeing it within your child welfare system, Sean? It's just obviously your caseworkers are still going out to homes. Are these children still going into the child care placements during the day? I mean, as part of that child protection plan. I've kind of wondered what happens to these most vulnerable Vermont kids?
Yeah, we have tried to maintain normalcy in their lives during the pandemic. Making sure our staff are engaging with those kids, but also making sure visits where appropriate are still occurring with their biological family as well, and also staying connected to their other systems of care that those kids access. And I would just say that our foster parents have been also carrying a pretty significant load there as well during the pandemic. And, we've been able to provide early on some financial relief to help them with that. And then also, we're able through with the Joint Fiscal Committee's approvals, provide some stipends in December to foster families as well. And so, that we continue to focus on that work and supporting that system of care because, with the way remote school is happening, that has an impact on our kids as well. And then, so we are trying to maintain as much normalcy and connection as possible with all of our kids in our system. So.
Senator Sears or Senator Westman?
No, I'm good.
Okay. All right. I understand that you've testified about the Woodside replacement in Senate institutions now. And in terms of where the projects stands, is there anything more that you need to update us relative to, we've just finished the budget adjustment. We included the language that the House had relative to the bond and review of the plans of the, design plans. And I guess we know you've got the public hearings with the community. Is there anything more to report since I testified relative to the budget adjustment funding?
I would just say that we are, as you indicated, we are beginning the public engagement process. So there's a hearing this Thursday, and I believe there's another one in early March. It may be the 4th, but we can get that for you.
Where is that hearing held, Commissioner?
It's going to be virtual, and we can share the link if you'd like to participate. We did send it to the delegation.
Actually, I've had a number of people who have contacted me who wanted to comment. I'll just send them to you, and then you can decide.
Are they residents of Newbury, Dick? Concerned?
I don't know that they're all residents.
Okay.
Somebody runs a summer camp for kids. Just contacted Mark McDonald and myself.
Well, there is a
Mary Hanson, Director, Camp Farwell.
Oh yeah, there's a very my niece went there. It's on Halls Lake in West Newbury.
Yeah, I'll just forward that to the commissioner then.
Sure. Okay. Thank you. Yeah, I would say the next steps are really engaging the community and then through the town's development review process for the approvals of the changes to the building that we're proposing. I believe we received an Act 250 opinion that given we're not changing the use of it and we're actually shrinking the number of kids that would be served in that facility than it was previously, that currently the way that it's being designed, it wouldn't implicate Act 250 review. But that's subject to the final design and plan. And one of the last pieces we're working on is the outdoor space for the youth, and that's the last piece that we really need to finalize, and the footprint and how that's going to be situated near the facility. And then moving on, jumping into our budget, we'll touch on the high level, the ups, just the things you normally would see, and the others, the Pay Act, the Fringe, the workers' comp. I think that what I'd touch on is you saw in the BAA, the creation of the clinical services director position, which was a position and funding. We had moved from the Woodside Dept ID that we didn't eliminate when we closed Woodside. And so it was in the BAA. You'll see that now in the 22 build. That position would be in the DCF Commissioner's office. SNAP revenue, needing to, with the loss of some federal SNAP funds, we need to backfill with some general fund. Our staff's random moment time studies are allocating less time to the SNAP program based on some changes we've made and just in our response And so, it's just impacting our cost allocation plan, and this just make sure we're in line with how we're drawing down funds. And then same thing with the CDF revenue adjustment. This one's net neutral. It's just moving the CDF dollars from the admin over to CCD, where they're able to draw it down, and then moving over general fund from their budget to ours to backfill that. And so that would be the ups you see there. The downs, we had a juvenile justice coordinator position that was sitting in the commissioner's office. With the creation of the adolescent services unit and the new adolescent services director, we felt like this position belonged in that unit, and so we're just moving it over here. This position in the funding, you'll see an up in FSD. It's net neutral. Same thing here. As we're proposing this year to move forward, with the, depending on the public health response on the timing, the community-based initiative, we had initially proposed moving a position from ESD over to OEO to help administer those community grants. And so this is the movement of the money in a position from ESD and aligned with that initiative. Sarah, I didn't know if you wanted to touch on the interdepartmental revenue transfer real quick.
Happy to do so. So the interdepartmental revenue transfer that you see in admin relates to the revenue swap between general fund and IDT to reflect the IDT that DCF receives from AHS in support of the IE&E program that we use for salaries.
You've used a lot of acronyms, and I'm sure people would want to know IDT, interdepartmental transfer, but you might
IE&E
want to just say that
is the integrated enrollment and eligibility program that I guess I would think of it as a data system development program. And then AHS is the Agency of Human Services.
Yes,
So-
Senator Westman.
Yes, all of the housing shifts, I'm going to need to sit down and go into in some detail. There are people that are quite critical of what's going on in this area. We even had some testimony last night at our hearing, and I'm going to need to go through it in depth.
We're more than happy to meet with you on that, Senator, for sure.
You can either give me some time, Sean, or early mornings are the best.
Sure, I'll have Chris reach out with some early morning, Comey reach out to you with some early morning times that work, and then you can just let us know which one works for you.
That would be perfect. My committee starts at 8:30, but once after that, I'm going all day. But the housing stuff, I'm really going to need to go into some detail to understand.
Sure, absolutely.
And we did get testimony as Senator Westman last night, particularly from legal aid, because whether we like it or not, the transfer of the General Assistance Program, which is really, for those of us who have been around a long time, including Senator Sears, in the world of human services or social welfare or whatever, that's the old overseer of the poor. And so it got brought in, and whether we like it or not, at times, in fact, it does provide a lot of legal protection in the form of appeals, in terms of uniformity, how applications are processed, and expedited reviews for emergency help. And so there's concern around the loss of those protections when you move it out to community-based organizations to respond. So that was some of the testimony we got last night, raising concerns about taking an inadequately funded program and putting it out to communities, and what protections are there for applicants that are afforded under the state administered approach. So that's a heads up to you.
Sure.
Yep.
The other one I would want to touch on here is we are reconfiguring how we provide service in the Middlebury office with our economic services division. We are reducing our footprint. It's our smallest office in terms of staffing and also the number of clients and walk-ins that we see on a regular basis. And so we are reducing our footprint and moving into co-located space with folk rehab, and that's allowing the Department of Labor to move into the building where we'll also be co-located with. And so we're booking savings on that. We are not reducing the service level that we're providing in person there. It's just the footprint will look different and smaller. We're just moving to the first floor and from the second floor as well. Some staff will be able to continue to work remotely from home, but we will always have a physical presence to see walk-ins and work with our partners that we collaborate with on a regular basis. And we're at it in the middle of a 10-year lease at the 5-year mark. And it's at this point that we have the ability to change the lease this year. And once we move past this year, we lose that ability. So this is the time we felt we could make this work, given the lessons learned in working remotely with the pandemic and the expansion of our technology and allowing people to access our programs and services electronically or over the phone have been greatly enhanced. And so we feel like we're able to reconfigure how we provide services. And we're going to look at this as a pilot and see if in the future, if this is something we can replicate in other districts as we learn from implementing this here in this new initiative in Middlebury. Also, here, the Orbis contract is, well, it's just transferring the funds in the contract to FSD where actually the services are rendered under the contract and just moving it out of the admin, it's net neutral. And then just, as you've probably seen.
Could you tell us what the Orbis contract is?
Yes, I can. If you hold on one moment, I believe I have it in my notes. It's for maintenance of support of the youth assessment and screening casework system, YASI. It's a web-based application. All right. Yeah. So.
All right. Yep. Senator Sears would. No. Well, when you say YASI, we all.
Yeah. It's a small amount, but it's the work is supporting FSD, so we felt like the contract and the dollars belong there. So you'll see.
And where were those dollars in the admin?
In the admin budget, and so now they'll be moving to the FSD Dept ID.
Okay. That's just a switch.
Yeah, just a net neutral movement of funds, and then just reductions in our internal service fund. And service level agreement adjustments, what we get billed back from HR and others is decreasing as well. And then moving on to family services. Here you see the juvenile justice coordinator position coming in. Here you'll see backfilling some interdepartmental transfer revenue coming in. We received some federal funds that come in through a grant to another I think it's the Vermont Crime Victims Center. There's been a reduction. Those dollars have helped support our domestic violence response and our domestic violence unit and family services, which is critical work. And so this just offsetting it with GF to make sure that we're able to continue to maintain that level of service, given that domestic violence permeates across the work we do in FSD in our districts. And so we just want to make sure we can maintain our ability to respond to the district's needs and our families' needs that are experiencing domestic violence. Here you'll see we're looking to restructure our transportation contracts and realign them between the Child Development Division and the Family Services Division. You'll see an impact in CDD as well. We spend a lot of money transferring kids in CDD and Family Services, and many of them are the same kids, just for different reasons. The CDD money is to get them to childcare, and FSD's to visits and other appointments when foster parents aren't able to transport the kids to their different appointments. So we spend a lot of money, and we think by restructuring it and going out to bid for a single state contract, that we'll be able to find some efficiencies as well and some savings, but also provide better service to families.
Who's providing the services now, Sean?
Sarah, do you know exactly the different, there's a bunch of different providers depending on the service.
There's
right now.
many providers. We have some parent-child centers provide transportation. Good News Garage provides transportation. Many different providers throughout the state.
And we can get you that list. And here we're hoping to, and we're getting close to issuing out an RFP to see if we can find one statewide vendor that can take this on and coordinate transportation across our systems. These two for the kids impacted in CDD and family services.
Okay.
Here, you'll see our third and final year of the phase down of our use of MCO investment for room and board in some of our residential treatment programs. And so to be able to maintain, you know, that system of care, you'll see it up in GF. I think it's is that $2 million, Sarah? I can't remember the exact number right here in front of me. I'm looking for it. I'm gonna shoot.
It's 2.2 million.
2.2 million, yes, up in GF. Also here you saw in the BAA, the Turtle Rock beds with Washington County Mental Health or crisis response beds. They were in the BAA here. You'll see them, the cost in the build as well. Important part of our system of care now. And then also, as you saw 1/4 of cost for justice involved youth and raise the age, 18-year-olds, and then in July 1st of 22, it'd be 19-year-olds. You saw, we asked for 1/4 of funding to start the initiative, the project in the current year. Here you'll see it annualized is just under $500,000. It's like $495,000. And we'll be issuing an RFP out soon to start that in the last quarter of the current year, and then moving it forward into next year as well. And then Sarah, I didn't know if you wanted to touch on the FMAC backfill for 4E.
Happy to. So with COVID, we've received an increase to our federal share for our 4E revenue, which has decreased the required state share. We booked those savings as one-time savings in the FY21 restatement, and here in the 22 build, you see us backfilling that.
And then another significant impact in our budget, putting an upward pressure, is the Families First Prevention Services Act, federal legislation that takes effect October of 21. There are some conditions for residential treatment providers to continue to receive 4E funding after the first 14 days of a youth's placement in their program. There's certain criteria that need to be met, and then also there's certain criteria that provider needs to meet to become a qualified residential treatment program. And we're anticipating that some providers are not going to be able to meet those new standards and will not be eligible to receive 4E funding, but they're a critical part of our system of care. One of those, Senator Sears is aware, the providers now will need to have 24-hour nursing care. And for many of our smaller treatment providers, that's going to be a pretty heavy, significant lift. There might be some providers in the state that will be able to meet this. And then also they need to be able to provide up to 6 months of aftercare once a youth leaves their program as well. And that would put a strain on our providers if they're able to meet that requirement as well. In addition,
Senator Sears, you have a comment?
Well, I've suggested that the commissioner and if need be the members of the legislature reach out to our federal delegation on some of these requirements in the Families First Act that seem more suited to large metropolitan areas and large programs. And for example, the nurses requirement, I don't know how a 10-bed residential program is going to afford a nurse, number one. Number two, there's a nursing shortage in Vermont anyway. So I think it's fraught with problems. And we should.
Mike?
I think we talked about this when we first got the presentation on the Family Services Act, but due to COVID, I think we kind of dropped the ball. But I do think it's time to contact Senator Leahy and others.
All right. My question, and then I see Senator Nitka's got her hand up, and that is some of these facilities are PNMI and come under Medicaid. So can you describe sort of the intersection of Families First requirements with what is required for PNMI?
Yeah, if we're not utilizing 4E, they wouldn't, they're not a 4E funded treatment program. This legislation does not impact them. We would be still subject to the Medicaid regulations and funding requirements. And you are correct that some of our providers in state, many of those out of state, the larger programs that we use for some of our youth out of state are Medicaid programs and will not be impacted. We see the major impact of the Families First Prevention Services Act on our in-state providers, many of our smaller providers.
Who are not a PNMI?
No, they're not a PNMI provider.
Right.
Yeah.
The non-PNMI
Yeah,
provided.
yeah.
Alice, you have your hand up.
I was just wondering, what about the proposed contract with Beckett? Does that include 24-hour nursing?
It will have nursing available. Yes, they will have a nurse on staff available 24 hours.
Thank you.
Okay. Well, because that's would that come under rate setted under PNMI?
Well,
or
they would
because
be,
of the
I mean,
secure.
well, then they will have nursing. This will be a justice involved youth, and
Okay.
not necessarily will be eligible for 4E funding.
That's what I'm
but
wondering.
yeah.
Okay.
Yeah. And
Other questions on that? Well, this is a new one, strategic planning contract elimination. I love that. It must be a euphemism for something, Sean.
yeah, this is a function that most, we all do, our divisions and offices do within DCF and across AHS and most likely state government. We do strategic planning, like 5-year plans. Many of our divisions do it internally, and we rely on in-house resources. And so we have a small amount of funding that had been identified for this purpose in FSD, and we're just going to use internal resources moving forward for their strategic planning purposes. And I'm proposing to eliminate the funding for this, what we had been a contracted service in the past. So coming in line with the way we've done it, we do it across the rest of the department. So. And then here, just the internal service fund down. And here, the Child Development Division. Here you'll see the same UPS, Pay Act, Fringe, Workers' Comp. One thing to highlight here, we have 18 childcare licensing positions. They went through a class-wide review, to look at, what they need to have for knowledge, skills, and ability based on the work they do. And that review indicated that they were not properly classified, that they were underclassified. And so they've been upward reclassified. And so there's an additional cost to us because there's an additional salary pressure with that reclassification for that class of position.
And that involves 18 people?
I believe it's 18, Sarah. Correct me if I'm wrong.
Yes, it's the licensing staff, not the techs or the director, just the actual on the ground licensors.
Okay.
And here, you saw this in the BAA where we transferred a position in the incumbent from the Family Services Division into the leadership team in the Child Development Division. It's working incredibly well and boosting the ability of the Child Development Division to meet the needs during the pandemic of all the different programs we're administering. And so now you'll just see that we're planning this to be a long, a permanent move of this position, and that we, once we have a vacancy somewhere else in the department, we will backfill the loss in the Family Services Division. But we've been able to absorb the work of this position at FSD by redistributing some of the duties, and other staff are covering them now. Here, the early care and learning CCFAP year 2. Remember last year, we funded that with one-time tobacco money. Now those funds are no longer available, and we're replacing them in the base with GF. And then also we're moving forward with the year 3, which we are calling the flip year. And so that at a cost of about $5.5 million of the rate restructure that we're doing. And Sarah, I'll have you touch on and maybe pull up that handout just a review of what that is going to entail. You're muted, Sarah.
Sorry. Did my screen change to the CCFAP redesign?
No,
No.
we still have the PowerPoint, or at least I see the PowerPoint, but.
Perfect. Let me just switch. There we go. Is it now on the CCFAP redesign?
Yes, yes. Yep.
So this is a fact sheet that we've provided in our testimony. It goes over our current child care financial assistance program, how we establish rates currently, where the fact that we use a market rate survey, the fact that we have co-pays that are set on a sliding scale based on that market rate survey and the amount of qualification for that a family qualifies, and then kind of what we're doing in the flip. So for the purposes of our flip, what we are proposing is rather than have the copay tied to an individual child in a slot, it will now be a flat copay for a family based on family size and income. So that means if you have 1 child or 3 children in a program, your copay will be a flat amount. The copay is assessed at the youngest child first with no additional amount for more than 1 child. We expand the eligibility by increasing the income guidelines up to 350% of the federal poverty level. And we pay the provider's reported rate based on the age of the child and schedule after the copay is assessed up to a capped rate. Our capped rate is tied to the 50th percentile of the 2019 market rate survey, which is our most recent market rate survey. And as you can see in this income guideline chart, it shows you a little bit about what a family can expect to pay under these new proposed income guidelines. So if you're 150% or below the FPL, you will have a $0 copay. And then if you're at a 350% of the FPL, you'd have a $200 weekly copay as a family.
And what I would point out here at the 150 and below, that's our reach up family. So our reach up families accessing childcare will not have a copay because they're under 150% of the federal poverty level.
They're so far under that.
Yeah, they're at like 60%.
Yeah.
So the money in this would fully implement this in 22?
Correct.
So when is the computer system done?
We anticipate implementing for October 1st in line with the new first module completion of the new CDD information system. And we need that information system to be online in order to implement these changes.
Yeah, that's why I asked the question.
Yeah, and we have some scenarios as well to walk you through in terms of the impact on different household compositions and income levels.
So my question was, so this is a rollout that would begin the new system in October.
Correct.
So the dollars, okay, that's all I was asking. Thank
So the
you.
question is it a 3 quarters and there's a quarter to be annualized?
Yes.
We calculated our payment based on next year and the caseload under utilization and what we expected it to cost for FY22.
But only a 3 quarters of the fiscal year.
For the start in October.
Yeah. So,
All right.
yeah, so you would see a different, based on the caseload, and you'd see a full year in the 23 budget at that point as we move forward.
It would be important to highlight that because the caseload is significantly underutilized at this point, it's difficult to project what that cost will be in FY23, depending on the utilization. It would be tied to the caseload at that point.
So we're having a lower birth rate. So is that having an impact? I mean, we just have fewer children being born.
I think what we're seeing, the major impact, at the current is the pandemic and the way families are working, and
Yeah.
many are working from home and choosing to have their kids stay with them instead of enrolling them and keeping them in childcare. They're juggling multiple things during the day, but making it work, keeping their kids at home.
So
Well, that would suggest that the caseload will go back up then when we're through the pandemic and the economy opens up.
So can I ask how our caseload is running, how much below what if I went back 2 years or went back to before the COVID, where are we?
So if you go back to the last full year before COVID, 2019, we're at 75% of utilization of 2019.
Thanks, that's helpful. And was this the new system based on what percentage starting October 1st that we compared to that?
It would be maintained. We're projecting the current utilization will stay the same into next year based on trends. And so it's based on that decreased utilization. So if utilization does increase, Senator, I think there will be cost pressures, associated with that.
Yeah,
increased utilization.
There'd be a budget adjustment at that point.
Yep.
So, okay.
Yep.
So in budget adjustment, we actually took money because the caseload was lower.
Correct.
And what you're saying is 22 is based on the 21 experience, which I assume is what your budget adjustment's reflecting.
Correct. Yes, we're projecting out based on that utilization trend into 22, but then we're reinvesting those saving caseload underutilization into this rate redesign and structure and copay flip.
Okay, so and I guess that raises the question was what was the estimated caseload in 21 compared to what we used for the budget adjustment?
Right.
Sarah, do you remember that those details?
I guess we use both for the 21 BAA and for the 22 build, we use the same caseload information.
Right.
We use the most.
Right.
But what is it? Because obviously when we built the 21 budget, the caseload was higher, and in the budget adjustment that we're going to pass tomorrow, if somebody asked me, what did you assume for a caseload in FY 21 versus what we are now projecting in the budget adjustment, what would that be?
So for this year, we used October data for the BAA and for the 22 build. For last year's budget, we would have used the previous October's enrollment data. So we always pull the same month in doing our projections.
I understand the methodology. I want to know the number of kids, what the difference was.
Was that 75%?
But 75% of what, Rich?
I would have to pull the number of kids, and it shifts every year based on how many infants are enrolled versus toddlers versus preschool.
Yeah.
So what we can say is that we're at about 75% utilization from pre-COVID, but I don't know the.
We'll get you those numbers, Senator. We'll share them with the committee. We'll get you the actual data used to make the calculation.
Yeah, that's all I'm asking is
tell me. I got it. We'll get that.
Well, you don't know the answer, do you, Rich?
No, I'm going to email Sean immediately to get it. But
Well,
it sounds like he's going to keep me to it.
Well, the only reason I'm asking was I was anticipating when I do the budget adjustment, and I'm saying we're assuming that this reflects savings in our childcare program because of a reduced caseload. If somebody said, and what were you assuming versus what you're experiencing actual, I wouldn't be able to answer the question.
No, I know exactly what you were asking.
Yeah.
I will say to you, Sean, I'll want to dig into the numbers when we sit down around that. Personally, what I would say is to build a budget based on the same as 21. Hopefully with vaccinations, we're going to come out what I would think that I would be looking at in October is we'd have a budget short. And so that would bring us back into a budget adjustment.
I think that's one of those, Senator, I would agree that if utilization goes up, that we would have some funding issues. But what we don't know is how the childcare market is going to respond. Right now, many employers have allowed their employees to work from home, and those families have chosen to keep their kids with them. If that continues even after the pandemic, we could see depressed utilization. I think there's still a lot of unknowns whether it will respond back to the pre-COVID levels, or if we're facing some permanent changes in our work behaviors and how we care for our kids based on that.
I totally get that. I'm just I want to go into it and understand your numbers and understand what thought went into producing that number. Because, my sense is that as we begin to come out of this, we may never go back to where we were previously, but I don't expect we'll be at the same low level that we were at during calendar year 2020 and in that piece.
But it's hard to project. That might be one we hold hands and jump off the cliff.
Yes, absolutely.
I apologize, my computer froze up there for a minute. So,
Sarah, you had a comment?
I would just add too that we do have a $3 million up in the budget as well to account for the CCFAP year 3 implementation, which would go towards increased utilization in next year, or to cover capacity needs of the field, because the field is still at a decreased utilization because of decreased demand or slots lost and different things. And we know from some of our regions that we've had that. So we are saying that we can cover that year 3 with the underutilization, but we do also have a $3 million up, which accounts for that increase in utilization that may happen, as well as bringing that base back up. So I just wanted to make sure that the committee recognized that there was a $3 million up. So when you net those two together, the difference is not the 5.5.
3:30. I just want to make sure that we get through the presentation. I think we were scheduled to what, 3:45 today?
Yeah. So, and I'll just have Sarah touch on this one example, and then we'll quickly move on just to show you the impact of the rate and copay redesign.
Happy to do so. So this sheet will give you some different examples for 4 different families, but this family is a great example of a family with 1 parent and 2 children earning $15 an hour right now for an annual income of just over $31,000 per year. They're at a 4-star center with a 50th percentile rate. They're currently paying $115 per week in a copayment, and under this new flip, they would have a $0 copayment. So through the examples, you can see the significant impact that this will have on families and the cost of care for them.
And then Sarah, we can just quickly move on to back to that. We'll provide this to the committee, so you'll see the other examples as well. There's like 2 or 3 other examples.
Okay.
And then going back, we just did, the major one here is the subsidy caseload underutilization, and we'll get you the data that we use to calculate that and how those were then reinvested in the year 3 rate and copay restructure. And then again, here you just see the money that was moving over to FSD for the transportation reduction as well, and the savings we might realize there with a statewide contract. So those are the big impacts in CDD at this in our budget. And then moving on, Office of Child Support, no real significant changes here, just what you would normally see for ups and downs in the Pay Act and the Fringe and the internal service funds. AABD, we're not projecting any changes in this program as well in terms of caseload. Moving on to GA, General Assistance.
You're not proposing any increase or adjustment to the state SUP either?
No changes, correct. Yep. Here you would see we're having pressures on the burial caseload, just where we're at. And so we're, you know, at the $1,100 per maximum we pay per burial, or, you know, we're needing about $60,000 in 22 to meet the caseload needs. And then here you would see all of the money we spend on, you know, for emergency housing, whether for motels or the money we transfer over for community initiatives administered through the Housing Opportunity Grant. Under our proposal, those move over to the Office of Economic Opportunity. And Senator Westman, when we meet, we can kind of really delve into those details more.
We'd like to, can you just tell me how many people do we send the $1,100 for burials for?
We can get you some caseload data on that. Yep.
And when was the last time we reviewed the costs related to that?
It was several years ago, and it was a decrease.
It would be helpful to me to be able to understand how much those burials and how it relates to the present costs.
Sure. One thing absolutely, we can do that for you, Senator. The other thing I would point out is the federal stimulus package that passed in December at the federal level did include some money to states for increased burial costs in response to COVID. I believe Vermont was in line to receive $800,000. We're not sure exactly how are the guidelines and guidance from the federal government, how those funds can be spent. But the state will be receiving some additional dollars from the federal government in response to COVID and burial costs.
Yeah, it would be helpful to understand how that relates to this, but I have to tell you, $1,100 for the burial of people, even with cremation, is not a lot.
That meets the very basic cremation cost for most of the providers in the state in this area. Moving on to the 3 squares, no changes here. What you see is just the dollars here are for the cash out portion of the caseload for elderly and disabled who receive it in a cash payment where we direct deposit it into their bank accounts. The remainder is EBT, around 80 million, you know, between 75 and 80 million goes out from the federal government onto the EBT cards directly, does not flow through us. This is just a cash out portion.
You know, I don't think, Sean, people really realize the amount of money that flows into the Vermont economy through this nutrition program. It's over 100 million. That's not inconsequential.
Well, yeah, and then when you add on the emergency full allotment and the pandemic EBT, it's gone up significantly. And now we'll be adding the 15% increase. So it's a significant amount of money every month into the Vermont economy, into Vermonters to help them.
Yeah.
Moving on to Reach Up. In terms of the up, you know, with the earlier stimulus packages, with the increase in unemployment benefits being paid and stimulus payments going out, you know, obligors who have a child support obligation or owed arrears, we saw an uptick in collections. And now we're seeing that go down, and these go into help funding the Reach Up benefit. And so this just makes sure we can meet the benefit need as we're seeing those collections drop back to more normal levels, you know, because than what we saw previously. In terms of down, in the restatement budget in September, it was about a $5 million increase in general fund and about a similar amount in COVID relief funds. You know, we were projecting based on what we had seen in prior economic downturns that we would see a significant boost in our Reach Up caseload. That boost has not materialized. Our caseload has actually continued to go down. Since April, we have lost 645 Reach Up caseload cases, and we're down about 16% in our applications. And so we're seeing a reduction of what we thought we would need to pay the benefits. And so the down here is a reflection of those caseload savings.
So, I guess within the realm of children, we're putting a lot into childcare. And we keep, obviously, they're a very well-organized advocacy. But this money is for parents to take care of or to meet the basic needs of kids. And many of them are on SSI and aren't able to work. So we're taking, in essence, we're taking the savings from Reach Up caseload and using it to enhance childcare reimbursement. I'm just saying, we haven't bought back fully the SSI reduction that we did. I'm not saying that we can do anything about it, but I think we need to understand that unlike reinvesting in the program, these are savings that are going to be used to support other programs that benefit children, but it means that we really are making no progress relative to the grants that are paid to the parents to take care of to meet their children's basic needs.
So can I speak?
Yeah, sure.
So what you're saying is we're taking money from low-income families and low-income kids to give to middle-class kids.
Well, I guess that's when you're getting into households at 300 or up to 350% of federal poverty, and you've got Reach Up families that are what percent of federal poverty again, Sean?
It's between 60 and 80%.
Okay. Yeah. So in essence, that is, yes, that is an unfortunate characterization, but I think.
But it's the truth.
Well, unless you find money that can support both. But in essence, yes, it's a redistribution of current spending or current state support for families, and moving it from one program to support another that has that have families with very different incomes involved. There's no question about that. I'm not sure that we can do anything about it, but I think we need to understand that we have those children that remain on Reach Up, and anybody who can work, obviously, or even if they're getting unemployment, would with a special add-on wouldn't qualify for Reach Up. But if you've got a parent who has a disability, and I know that we have a certain number of those families, some of the children themselves, and the parent is needed to care for that child with a disability. You have got some that can work, and you've got some that have very legitimate reasons why they're not able to participate in the workforce. So it is, I'm only bringing home how pitiful the amount of money we give to families to pay their rent. And if I don't know what the new amount is for Reach Up, it was like $740, I think, a monthly benefit or something for a family of 3.
Yeah, we just.
And I know that we.
Yeah,
what?
we just provided some, Stephanie Barrett from Joint Fiscal Committee asked, Joint Fiscal Office asked for some data on the current benefit structure, and we provided that. And so we can share that with the committee as well.
Yeah, I'm sure she's asking because it's something that, I used to have a handwritten note in my drawer. So we talk about not paying more than 10% for childcare, and that's a wonderful goal. But when you're paying a family of 3, that amount, it's hard to even cover the rent with that unless you are lucky enough to have a Section 8 voucher. So it's something that I just think we should put out on the record, that when you advocate for one program and the funding for it, how does that look relative to how we're serving our poorest children in the state? And then we talk about the impact of poverty on children. So it's for me, it's a source of some consternation. And I wish we could do something about it. But we'll keep going because I know the budget, I know the budgetary constraints that the commissioner is functioning under. But when we're making decisions, it's important that we understand where the money is coming from and where it's going.
Jane, Madam Chair, this is
Yes.
Senator Ballant. Commissioner, do you have readily available to just, since I'm new to this committee, how many children currently, are in families that are taking, are part of the Reach Up program?
We can share, we have that data readily available, and we can share that with the committee and send it on.
Yeah, and the caseload has gone down. It hit a peak of just a little over 28,000 parents and children in the mid 90s, just before we really implemented our Vermont's, which is actually so different than most states, welfare reform. And it was down around 12,000 maybe a year ago. And so the number of children who are welfare dependent is at a historic low. There's no question about that, Senator Ballant.
Okay, just wanted to get a sense of the.
But
number.
obviously, we.
Even one is too many.
Yeah, so except there are, as I say, families for very legitimate reasons who really are dependent on this benefit because
Absolutely.
of their own circumstances that prevent the parents' ability to provide the economic support for their children.
Yeah.
But we have the numbers, and the caseload is very different now than what it was. But we'll keep going and get that data for you.
Yeah.
And
Also,
that's
Deborah-
why in the report that we've gotten, the unfunded mandates is out, and this committee should look at it because that every year we hear that we're not fully funding the full amount. We're notwithstanding the transfer of the property transfer tax to VHCB, which is true. And there are a number of areas, if we were to fully fund the standard of need for Reach Up families, it would take over $20 million to do that. So if you want, you can go back to that report because it is helpful in terms of what we have for commitments relative to what we're paying. So I'm going to have you keep going, Sean, and I'll
Sure.
stop pontificating. But you can tell, as I've said to the committee before, I'm still the old state lady here because the way in which these children and families are supported today is so much less than what we actually did back in the late 60s and early 70s.
Sean, before you, after we had all of that, it's good for us to go through that. If there was a chart with a line and the funding history for these families, not the overall, but what they receive. Because we just did something very tiny for them, but we haven't done the amount of increase that each of these individual families would get is pitiful.
The other thing that we have not done for a long time too, and I asked about that in the state supplement to the SSI benefit, the old AABD program. So you can see we've got some long memories here in terms of if you want to look at that other population, which is the old aged, blind, and disabled population. Those used to be two programs that we said were our priorities for funding, and for there were years we always funded for the 100% of the standard of need, and that those days are only a dim memory at this point. But it would be helpful to see, just track what that benefit looked like because it's been a downward percentage of the standard of need. Not that necessarily the standard of need is the right metric at this point. It's very outdated methodology, but it's still a benchmark.
So we will provide that data to the caseload data and the child count data and the benefit data to the committee as well.
Okay, all right. So let's keep going here because I realize it's Q4.
Sure. Also, we're looking to provide some efficiencies. We work very closely, with DEVA on transportation and the Reach Up program. And here is just looking to find some additional efficiencies. Again, and trying to streamline our providers and how we deliver service. Right now it's a very bifurcated system, and we're trying to, streamline and hopefully find some efficiencies, but also provide a better service to families in terms of who they call and how they access it. Right now, it can look different depending on, what type of ride you need and where to. And so this is just looking to make some improvements in the system and also hopefully find some efficiencies as well. And then moving on to LIHEAP, no changes here in the program. In terms OEO, here you would see, what we talked about from the DCF admin where the ESD positions are located. You see the position transfer in. Also, the emergency housing money coming in as well from ESD, that was 6.2. But also there's an additional appropriation to support the community transfer of $2.4 million additional investment for the community-based model moving forward. And then here just some small downs regarding internal service funds and Fringe. Weatherization, no changes. We did touch on the one-time appropriation of $4 million, which we would spread over 2 years, and working with our community action agencies to increase the number of homes that they weatherize across the state with those funds. We contract with primarily our CAPS, one area. It's a different organization in the state, but that's how we would utilize those over a 2-year period. The secure residential treatment, this was the Ebt ID formerly known as Woodside. Here, with the state not running its own facility any longer, and that we're moving forward to a community-based provider, you will see that moving to a grants line item in this Ebt ID. And then also you will see the clinical director position transferring out. And then also you'll see just a little bit of us, we've been able to claim a very small amount of Medicaid funding with one of the youth that had been at Woodside but was moved to a Medicaid treatment provider, and we were able to recapture some costs based on how we're serving our kids now in different treatment settings with the closure of Woodside. And it's a very small amount of money. I think it's like 30,000, Sarah. And then in the disability determination unit, again, just a small, this is almost primarily 100% federally funded. This program, there is a small amount of GF, so you'll see an up, on Fringe and workers' comp, and then just a small down of in the Eternal Service Fund. Yeah, and I believe that's it for DCF.
Senator Starr, did you have a question?
Yeah, I was wondering what happened to the personnel that was at Woodside, Commissioner.
Yes, so they went through the contractual process, and I believe many of them are in new positions in various parts of state government. I know we had some go to the Agency of Transportation. We had many stay within the Department for Children and Families and go into other divisions. And I believe everyone was offered a position. My understanding is 1 or 2 may have turned those down. And I don't know if they've been offered a new position because they have the ability to be offered several positions, but almost all of the staff have secured other positions through that process in state government.
Mm-hmm.
Yeah. I didn't know if, thank you.
Yeah, because they're classified, they have RIF rights, and they can actually bump other employees, or they can take vacancies. So there's quite the way in which it has to be handled is all prescribed under the contract, unless you have a few exempts, for example. But it's well established when we've done. Oh, it was massive when when the week school was closed, or Brandon, but this is still a relatively small number, but still some disjuncture from it. The only other comment that I would make, just historical, and that is Reach Up. It used to be under the old 4A. It was a match program. So this is an example of what happens with block grants as well. Is any additions is all on the state side, because that block grant hasn't been increased since the Clinton administration, to give you some idea. So you can see why states are loath to get into block grants, because the history on block grants is pretty dismal. So other questions that we have, and I see Sarah's provided the information on the rateable and what that will be. So other questions that anyone has of DCF? No? Okay. Obviously, there'll be quite a bit more discussion around the replacement facility for youth, justice-involved youth, and then any transfer of housing, and then of course the other, and that's the transfer of the child development division to the Agency of Education.
Yeah, so there's no impact budgetarily on that this year. That would be where you would see that initiative impact the budget in positions would be in 23.
Yeah, no, but I'm just saying that's a major proposal out there that's been advanced by the administration.
Absolutely.
So I guess you'll be hearing Senator Westman, and we'll put you through the usual drill, and we will let you get back to your work that you have and call it a day for appropriations.